It's with great pleasure that I introduce the lead for the National ODN programme, which is Professor Ashley Brown, and the head of the programme in NHS England, Mark Gillyon-Powell.
Okay, thanks. So welcome everybody. We're going to do a little bit of a double act. First of all, just thank you for the invitation to come and speak today. It's great looking out at the sea of faces, that the enthusiasm, the push is still there. So we're just going to recap basically what we've achieved so far. But the big question I know a lot of you have is, where are we going from here? I'll leave that bit to Mark, but I'm just going to do just that one there. There we go. We up? Yes. Okay. I'll give an update of where we are now, and then Mark will tell us where we're going in the future. So what have we delivered so far? Thinking back 5 years, it's actually quite nice to see that there are still some faces here who were in the room 5 years ago, metaphorically in the room, but also new faces. Things have evolved, things have changed. I think really that the basis of what we have achieved comes from the decision to set up those 24 operational delivery networks, where we were given the autonomy, we were given the funding, we were given the ability to actually develop services in our own areas. Many of you are still working for the same ODNs. Others of new faces have come in as the program has moved forward. So we have those 23 geographical ODNs. All of you have different needs, different challenges in your own geographical areas, and you've been given the autonomy to sort that out, and you've done that very successfully. More recently, of course, we've developed the Paediatric Operational Delivery Network, a smaller cohort of patients that need that specialist care, and have brought the paediatricians and to a certain extent the obstetricians into the fold so that we can actually move forward, treating children now as young as 3. We've given the oversight, we've given the ability to help you find patients, primarily through the funding that's been provided by NHS England and the support that our trusts, hospital trusts, have given us in order to deliver those services. None of this would have been possible without the cooperation and the collaboration with the pharmaceutical industry, in particular the strategic procurement that was obtained by NHS England that has actually allowed us to use these drugs in a way where we can literally access everybody. And when you look at other countries where this has not been achieved, much of that comes back down to the financing of the pharmaceutical component. And that's really where we've had that head start. Of course, in order to achieve that, we have had this requirement to fix the market share, and we've done incredibly well to actually fine-tune our use of the various medications to make sure that we come in under that contract. We're doing less well at the moment. Perhaps we can talk about that a little bit later. There have been specific elimination initiatives funded by the pharmaceutical and delivered by the pharmaceutical industry that's actually enabled us to move forward, and that's been incredible. And it's about partnership. I think for so long, previously, we were working in our little silos, in our trusts with our teams. But what the operational delivery networks have shown is that by partnering with other agencies, with NHS England, with the UKHSA, with the pharmaceutical industry, with the third parties, the Hepatitis C Trust, the other charitable and third-party sectors, we've actually been able to deliver this care where it's needed, out there in the community, particularly amongst many marginalised groups. Primary care, we're slowly getting there. GP champions are moving us forward. We need to do more in primary care. I was really interested to see that over half of you, I think, said that where we need to be doing more testing is in primary care. We know that there's a big reservoir of patients there that are not identified in other ways, and that's really where we need to put our attention. So by year 5, we're halfway through year 5 of what was planned to be a 5-year program. We're doing incredibly well. We're not there yet. We need that final push. Many of you will have had your accelerator meetings. Others of you hopefully have got your accelerator meetings booked. These are not CQC inspections. We're not coming out there to tell you you're not doing the right things. We're coming out with the elimination meetings to say, what additional services, what additional resources do you need to bring everybody up to that finishing line so that we can actually announce elimination. And we will be making announcements with that in due course. So what have we achieved so far? Unbelievable. 84,000 people have been treated through the ODN network for hepatitis C. Every single one of us in this room can think of individual patients who we have successfully treated. The effort that goes in sometimes to engaging individual patients, individual clients, getting them onto treatment is incredible, but it's thanks to people out there. And every single one of you, I'm sure, will have recognized the benefits to individuals, how we've treated them. And again, 80% of those treatments have gone to the most deprived half of the population. So this is about equity of access. This is about leveling up, if you like. This is about actually reaching out to some of the more marginalized community members and bringing them into the fold, offering them treatments that previously in the interferon era, we'd have really struggled to deliver. Over 100 children have now been treated. Again, for those of you involved in pediatric services or family clinics, the relief of those parents, particularly when we're talking about vertical transmitted children, the relief of those parents to see their children treated at an age before any of that stigma comes out, before the child even is really being burdened with that concern, is really dramatic. 37% reduction in deaths. Put that into perspective. These are people who, without the intervention of the DAAs, without the intervention of the elimination program, would have been facing death. And a 52% reduction in the number of liver transplants that have gone to patients with Hep C because they no longer need that liver transplant. And that's freed up those transplants for many of our other patients. So we've achieved fantastic things. We want to keep the momentum going. And at this point, I'm going to hand over to Mark, who's going to fill you in on where we go from here. Mark, over to you.
Thanks, Ashley. Really interesting how far we've come. And Ashley mentioned we're in the middle of year 5 of a 5-year strategic procurement. So obviously, probably on most people's minds is what happens next. And I'll just give you a brief update about that as much as I'm able to before I look at what some of the program elements are likely to be for future years. Earlier this year, we had initial discussions with each of our pharmaceutical industry partners to see if they would be interested and willing to extend the relationship that we have with them for a further 2 years. So effectively years 6 and 7 of a strategic procurement. So we had those initial discussions, and subject to contracting and details, all of our 3 pharmaceutical industry partners were very positive about both the work that's been achieved so far, but also about getting the job finished, really, which is what we're talking about, making sure that we actually do get across that finish line. So we've had further discussions more recently, last week and this week, and we will be taking forwards as far as we can negotiations around what year 6 and 7 would look like. Obviously, that's all still subject to legal ratification and the sign-off of the senior management of the, often international senior management of the pharmaceutical industry partners. But as things stand now, I feel hopeful, personally, I feel hopeful that we will have years 6 and 7 of the strategic procurement, which will give us some certainty around elimination initiatives and programs going forward. Years 6 and 7 may not look exactly like years 3, 4 and 5, because what got us to where we are now isn't necessarily going to be what gets the job finished. So there will be nuances and there will be changes. But I'm feeling personally optimistic that because of the great partnership that we have with our pharmaceutical industry partners, we've got somewhere to go, somewhere positive to go as we move forwards towards elimination. So really, in terms of what we've prioritised and what we plan to prioritise, or what we should probably prioritise next, obviously, early in the programme, we had a whole load of people who couldn't access interferon-based treatments, didn't want to access interferon-based treatments, or couldn't complete them. So we knew that we had a lot of people who were ill, and quite rightly, they were prioritised for treatment at the time that DAAs became available. We're kind of in, I would suggest, probably later part of phase 2 now, where those that we know who are likely to have Hep C and are potentially at the greatest risk of onward transmission, either because of injecting patterns or where they are in terms of their situation, so being homeless, being in prison, an increased risk of infection. And those are the people that really over the past few years we've had a very kind of clear focus on. We're doing focused testing initiatives in prisons, in drug treatment services, in homeless centres. Still some more to do, but actually we've been given that quite a lot of focus, and we need to consolidate that, I think, is the thing for now. Phase 3, which I think we're kind of running in parallel with the beginning of where phase 3 is, really in order to achieve elimination, we think that there may be up to 70,000 people left with hepatitis C in the country. And they're going to be people that we haven't yet been able to access. So that'll be all the people outside of structured drug treatment. So people who are injecting and not accessing structured drug treatment. Some of them might cycle in and back out again, but some of them just won't ever come near. And we need to work out how best we can find them, support them, and enable them to access testing and treatment, and encourage them that that's a useful thing for them to do. But also, there are people who don't know that we're looking for them. So the people who might have historic risk are sitting in primary care, injected in the 60s, 70s, 80s, haven't done anything since, haven't had any risk factors since, don't know that we're looking. So we need much more around finding those people. So things like increased and enhanced case finding in primary care, which we'll talk about a bit this afternoon, expanding the availability of the emergency department testing program, opt-out testing, which has been hugely successful to date. But actually, there are more places that could be doing that, and it would give us a good cross-section of society to be able to understand what levels of infection are still remaining in certain communities. And then also the people who don't necessarily want to get tested in any of those settings. We need to be promoting the opportunity to self-test. And I think COVID did us a real favour around that. People are more used to self-testing than they were pre-2020, getting a testing kit and doing it themselves. And of course, any over 18-year-old in England can now do that really quite easily in terms of accessing a testing kit and testing themselves. And if positive, they will be automatically linked into treatment. So it's getting those kind of more community population level measures into place, I think, is a key priority. And then where do we need to make further progress? And this is a direct quote from every school report I ever had. Satisfactory, but must try harder. Current risks, I mentioned those outside of drug treatment services, those that we're missing in prisons or in the homeless population, in migrant provision, those that we're missing in antenatal, because antenatal testing is still patchy. In some places opt-in, in some places opt-out, in some places not at all. So we're working with a number of ODNs about how we can introduce antenatal testing to get hold of people who might have been at risk recently or are currently at risk. Communities where we need to work much harder and further into, people born in or travelling to South Asian and Eastern European countries, especially former Soviet bloc countries. We need to do a lot more. We've got some plans with the web testing portal, but we actually need to do more with each ODN to kind of say, what's the makeup of your population? Who aren't we reaching? And how do we reach them? How do we best do that? And also, I think we need a proactive review of women who test positive or have been treated in terms of whether they've had children. Some ODNs pick this up really well with every case, every woman who's treated, some don't. And we haven't necessarily historically done that with women in prison either, who may or may not still have contact with their children. So I think there's a detailed piece of work that we're discussing with Hep C Trust and the paediatric ODN around women in prison, but there's kind of a wider piece of work about making sure that any of those children that have been born to Hep C positive mothers are also picked up for testing. Population-wide, it's a test. We need to test as many people as we can in as many different settings as we can, so that we can make sure that of those 70,000, we've made the biggest inroads into finding people, promoting the web testing portal, as I mentioned, GPs, pharmacists and community vans, which I think are all incredibly important ways for us to get out to people who don't necessarily identify that they've been at risk. And historic risk, as I mentioned, people in primary care, those in recovery, those who've been infected through blood and blood products. And I've put 62.3 million other reasons, because that's how many people are engaged with primary care. That's how many people are on a GP's list in the country. So every one of them, potentially, we need to assess what their risk has been, which is a huge task, but we've got some plans about how we can best target that. And as I mentioned, emergency departments. So really, national priorities for this year, as well as getting us over the line with years 6 and 7 of the strategic procurement, which as I mentioned, I'm very hopeful about, and I hope we will be able to announce something possibly during October or November in partnership with our pharmaceutical industry partners, all being well. We have been working to shorten and simplify the diagnostic and treatment pathway, and we maybe just briefly come back to that in a moment. Consolidating that targeted testing, which I mentioned. Primary care, which we're going to cover in some bit more detail this afternoon, but primary care is a huge opportunity for us to find people who we won't necessarily find in drug services, sexual health services, and other venues. Universal and population testing opportunities, so ED opt-out, antenatal and the web testing portal, and reviewing who's been lost to follow-up, and then some specific programme reviews, like I mentioned with the women who've been through treatment, and understanding better how we can engage people in treatment and not lose them to the system. I'll just leave this up because I leave it in every slide deck that I do now. Don't forget to promote the web testing portal at every opportunity. We had a piece of work specific last week and the week before around people who may have been at risk abroad through tattoos, piercings and so on, or through medical treatment following accident or injury abroad, or even elective medical treatment where people go and get turkey teeth or whatever. So a big push on that over the last couple of weeks. The day that the press release went out, there were an additional 1,092 orders on the web testing. So we can see that doing the promotion, getting it in front of people, actually really does make a difference. People had just seen that on the news or in their paper or online, and it really drove a lot of traffic to the portal. So anything that you can do locally to drive that traffic, especially amongst people who might not access testing elsewhere, is really important. And that was it.
Thank you very much.
Questions?